Hi, and thank you for letting me share my Firemore grant with you. My name is Rebecca Nagel, and I am a clinical assistant faculty here in the College of Nursing and Health Sciences and a pediatric nurse practitioner in primary care. Our grant was Culinary Medicine, a teaching kitchen and interprofessional service learning curriculum. Other team members include Christina Harlow, who is faculty here in the College of Nursing and Health Sciences, Leah Pryor, who is chef executive at UVMMC and a chef educator, Emily Claremont, who is a registered dietitian at UVMMC, and Jana Lichenfield, who is an MD in the Larner College of Medicine here at UVM. So to give you a little bit of background, culinary medicine is a new evidence-based field combining the joy of cooking with the science of nutrition. And food agency is a pedagogy developed with a team of individuals, including Dr. Amy Trubeck here at UVM, which empowers students or individuals to cook for themselves on a budget, increasing their ability to start connecting cooking with health. So culinary medicine empowers individuals to improve their own eating behaviors, thus leading to enhanced food agency, improved food security, and in the prevention of obesity-related chronic health disease. Despite these associations, there's not a lot of consensus and research around culinary medicine and the integration of culinary medicine into both medical and nursing curriculum. A review of 10 culinary medicine programs found beneficial correlations between food preparation in the kitchen lab and preparation of healthy meals at home, and that was in 2016. The prevalence of obesity in all age groups is on the rise in both the United States and worldwide. We know that dietary behaviors lead to obesity, cardiovascular disease, metabolic disease, and cancer. By 2020, the World Health Organization predicted that 2/3 of all diseases worldwide will be the result of poor lifestyle choices. We also know that evidence shows healthcare professionals remain inadequately trained to initiate or affect patient change in nutrition and food choices. In a pilot study done by Montezula in 2015, examined a medical school-based teaching kitchen with hands-on Mediterranean diet-based cooking and its impact on patients with type 2 diabetes. This study was a randomized controlled trial including 954 medical students, and it demonstrated improved biometrics in the students with this hands-on training, with a 95% improvement in increased consumption of fruits and vegetables and improved attitudes towards nutrition competency and individual cooking behaviors. So a brief overview of what the modules and the curriculum looked like. We had 16 students who self-selected to participate in the curriculum. The experiential kitchen sessions took place at the kitchen lab here at UVM, led by Leah Pryor, the chef educator, and Emily Claremont, the registered dietitian, and I was also a facilitator in those sessions. Initially, pre-COVID, we had the first two modules happening in the kitchen lab where with 8 kitchen stations and partners paired up. The stations had all of the tools needed and the ingredients for each of the featured recipes. With COVID, we had to make a transition and we had 8 students in the lab and 8 students cooking at home in their own kitchens. And it really was enlightening how effective it can be to use Zoom and have students working in their own, kitchens. So that was a really fun way to continue the curriculum despite COVID. For those sessions, the students that were at home, we were able to put together ingredient kits that they could pick up prior to the session. Overall, the curriculum that was developed utilized the Health Meets Food courseware out of George Washington University. The pedagogy really looks at the technical skills of cooking, navigating the barriers one might have to cooking for oneself, incorporates mindfulness with mindful and intuitive eating, thinks about how to cook on a budget. So both the tools and the ingredients used were really with budget in mind, which addresses food insecurity, health access and health equity. We also highlight the importance of cultural and social influences in cooking preferences. The tools that we used we did quizzes, both pre and post curriculum for each of the modules. We had a qualitative questionnaire and a NIPS, which is a nutrition and patient care survey that students completed prior to starting the curriculum and at the conclusion of all 4 modules. The nutrition and patient care survey, we used the modified 15-item questionnaire that is a validated tool that really looks at providers' attitudes towards nutrition and patient care. So we presented material from a health promotion and prevention standpoint, enhancing the students' ability to utilize food for both health promotion and prevention of disease. The modules are listed here, and the first is an introduction to culinary nutrition and the Mediterranean diet. The second is looking at diabetes in both prevention and treatment with carbohydrates, fiber, snacking, and desserts. The third was around cardiovascular disease and hypertension, really talks about renal physiology, sodium and potassium homeostasis, sodium reduction, and flavor building. And the last module looks at protein, amino acids, protein in vegetarian diets, and a discussion of disordered eating. Service learning develops caring and competent providers with heightened awareness of health disparities and connects students to real-world situations, improving communication skills. Because of COVID, the service learning portion of this grant was not able to be completed, but we hope in the future of really including this as part of this curriculum integration. So an overview of the findings, we didn't have a whole lot of difference in the pre and post NIPS survey because most students self-selected to join the curriculum and were really eager around nutrition and nutrition counseling. So all students felt that nutrition counseling should be a part of routine care regardless of their specialty, that nutritional assessment and counseling should be included in routine appointments, health promotion, but also including diagnosis and treatment of disease. And that overall students do not feel adequately trained as DNPs to provide nutrition counseling or when to refer to nutrition-related services. Our qualitative findings really aligned well with the curriculum and incorporated all of the goals that we had. So I don't have time to really review all of those findings, but they really were in alignment. So with this grant, we identified a gap in knowledge in DNP curriculum. We found that the integration of culinary medicine curriculum modules into existing classes can be a really effective way to address this gap. That education materials and learning activities developed for this project are a feasible and acceptable solution. And that we really hope with this curriculum we can contribute to a growing body of evidence that integrative nutrition is beneficial to students, patients, and communities. And on that note, there's currently no research and evidence around NP-based curriculum in this area. So what are the implications for practice for our students? Culinary medicine and food agency and the investment in these skills will likely lead to improved physical and mental health for our students, improving their own health and well-being. It also allows them to incorporate nutrition for their own lives and for their patients in both the prevention and treatment of disease, using good examples and case studies throughout the curriculum. The mindfulness and resiliency training, again, will improve well-being and will help students practice with these tools and strategies that they could then use in patient care. and then really looks at promoting food security, and by teaching skills on cooking on a budget really helps starting to address food insecurity, health access, and health disparities. Well, thank you for letting me share this grant with you. And my hope is that you will be seeing an integration of culinary medicine into the DNP existing coursework and curriculum, that this will increase food agency, food self-efficacy of the DNP student, and really start to increase the confidence of our students in utilizing nutrition counseling in patient care. Thank you.